Hello and welcome. Today's session on AI in clinical practice. We will be talking about the global burden of medical errors. Actually, it's a big issue. Only thing is, it does not get that much of media publicity because it is something happening throughout the year and it's a sort of an undersurface problem. Only to one or two incidents will attract media attention and blow up. But whereas an aircraft crashing with 300 people will make headlines, and immediately the governments, the stakeholders, everybody will get into the action to prevent a next aircraft from crashing. But it's not so with medical science. Number one, medical science as such is imperfect. Very difficult to tweak it and keep it in ship shape. Number one. Number two, it is sort of something, happening under the surface, and diseases and their progression have so many factors that very difficult to pinpoint where things went wrong. At some point we need to get our act together, and governments and stakeholders have looked into this, and WHO has released statistics to the extent that up to 4% in low and middle income countries they face even death as part of the as a consequence of medical error. So the disability and the discomfort figures will be much more. Unsafe medical practices cause quite a number of daily lost years, and that's quite huge. Now, what about the expenditure? It is not only the upfront expenditure, it is also the expenditure you can compute to the days lost, to the relatives who have to bear the burden. If for all you know, the breadwinner himself will stop working and become a caregiver now. Lot of things which can pull people down their earning capacities. So it's up to 10% of healthcare costs is going to rectify errors. So preventing errors is critical for patient safety. Not only that, for healthcare efficiency itself. You cannot be having costs which are plugging in problems. So now medical errors, let's have a look. They will be due to misdiagnosis, medication mistakes, surgical errors, document issues and communication. There are a whole lot of factors here. But let's look at misdiagnosis. So there is a whole lot of problems happening at the diagnosis level itself. Next only you will bring the medications. When your diagnosis itself is not safe, naturally the medications that you give to an unsafe diagnosis is going to be full of mistakes. So when your diagnosis itself is a problem, your surgical errors will compound that. So this is how you have to tackle the core problem, that is misdiagnosis. In the core problem, are there factors which can be broken down? Once you break down a problem, it's very easy, or rather it's much easier to find a solution. So what are the factors for the problem? Inadequate patient history, time constraints, blah, 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 whole lot of things. Inadequate follow-up or failure to reassess. You sort of put the blame on the patient now, saying he didn't come for follow-up, he could not afford follow-up, he didn't care for follow-up. But if you really look at it, it is the cognitive bias which lead to 70%. This is not my opinion, this is from PubMed. So now, can we tackle this alone with AI? We are not going to take an exhaustive presentation on tackling all these four, neither on all these, but just on this particular aspect of misdiagnosis. Have a look. Errors in diagnosis. AI improves nodule detection on chest x-rays in a health screening population. See, these are patients who have not come with symptoms. They are patients who have just been screened for chest x-ray, with chest x-rays. So there is a doubt. Could there be something there? But it is still a doubt. If you want to look very keenly, or because you have found an AI support there, you might pick up this nodule. Otherwise, that nodule will miss. Now, when you use an AI, you can find out that it is drawing your attention, and not only that, with 80% accuracy. AI is not sitting and telling half. No, it has almost got enough ground to predict with 80% predict with certainty. So, a little bit into the computation part. What do? You present this image to the AI. So the AI will collect clinical data. It already has the text data and the imaging data, like your ultrasounds or your CT scans or your X-ray chest. So this has got the features for the model to analyze and learn. Then there is something known as an artificial network here. So they sort of keep on processing, and these are all mathematical. There are weights, there are tokens, there are a whole lot of things. I'm not an engineer, and very difficult for me to understand the core mathematical equations. But as an healthcare professional, if you know this much, it should suffice for you to get into AI, to think about using it in your clinical practice in a very wise way. So this artificial neural network has got multiple layers: surface layer, input layer, output layer, and some hidden layers. They keep on computing these inputs and directing to other nodes. Finally, they come out with an output. This computing within their nodes is done by training data. Finally, they give a diagnostic output, and it's sort of a second opinion for clinicians. You see this X-ray, you could not make out this very small nodule, but maybe a very trained physician can pick it up. But it's not as if all healthcare workers, the moment they enter the workforce or the moment they they encounter a particular type of patient, is going to have all this experience with them. So if you look at AI, it's a sort of a collective experience of millions of physician brains which have put their act together. So you use AI and you get the uh, accuracy of up to 80%, and it's actually like using a senior consultant. But for this, it is not that simple. There are a lot of factors for the ethical use of AI, and to make AI safe. That is very important. We need to make sure that all the million physician brains were physician brains, and the data was not tweaked or altered in some way. Now, coming, as I told you, we have talked about medical errors, that is as far as diagnosis is concerned, how AI can help. Further down, I'll be talking about some of these other factors and the rest of the compartments also. Inadequate patient history, in a way, yes, you can probably sort it out with scribes. But coming to examination, as of now, it belongs only to the clinician. There are some visual triage tools available, but that is only in emergency to do a gross triaging. It has not yet come to make the diagnosis on physical examination. So thank you very much. This is on behalf of DocStribe AI, the company where I work as a subject matter expert. And please, I keep asking, please post your comments in the comment box or in any of the social media handles, and I'll be very happy to answer them by looking up the answer. Again, thank you.